share your insights and ask questions via the Q&A box underneath, so we can discuss them during the panel discussion at the very end of the session. So to start with, I want to welcome you to our first session on the learnings from the Mosaic workshop. So this is the management of metabolic dysfunction associated steatotic liver disease and cardiovascular disease. And it's a real pleasure to be joined by my co-chair, Professor Michael Bohm from Saarland University Hospital in Hamburg in Germany. And we're also going to be joined by a very esteemed panel of presenters today. So that includes Professor Fayez Zanad from the University of Lorraine in France, who's going to be presenting on MASLD and cardiovascular disease. We've got Nicholas Chu from the National University Health System in Singapore, presenting screening and diagnosis. And we've got Cyrielle Saucy from the Hospital Lyon Sud in France, presenting on management. And then we're also very fortunate to be joined by Andrew Coates from Monash University in Australia. It's probably very late for you, who will be joining us for the panel discussion at the end. And after all of the presentations, we'll conclude with, as I say, a panel discussion that will last about 20 to 25 minutes. So please do stay to the end and ask questions. So I'm now delighted to pass over to our first speaker of the day, Professor Fayez Zanad, for the first presentation. Thank you.
Hi, thank you for having me. I'm Fayez Zanad from University of Lorraine in France, and I'm really pleased to share with you some innovative thoughts on the interaction of cardiovascular disease with another disease silo, I would say, which is a MASLD and usually called NASH. And it's important really that we get to the new view that this is maybe a single entity. Indeed, when it comes to the epidemiology of metabolic liver disorder, we can see that it is literally exploding. The numbers are really, really high. And therefore, no matter that there is an interaction between this very highly prevalent condition and the second, maybe the first reason of death, which is cardiovascular and by extension, cardiorenal metabolism. This is just one of the metabolic diseases, which is diabetes type 2, and you see how much this is interacting with MASLD, and the frequency of MASLD is extremely high in patients with diabetes worldwide. Now, the cardiorenal metabolic diseases have significant global prevalence and many conditions overlap. This is the key message I would like to share with you. Look at only the 1.6 billion people living with NAFLD. And of course, this interacts very much with people with diabetes, with obesity, with CKD, cardiovascular disease, and more so among the cardiovascular diseases, heart failure. So this is the global prevalences and with individual silos. But of course, you may think that all these silos overlap, so no longer being silos, because there are common cardiometabolic risks underlying MASLD, MASH, cardiovascular, and cardiorenal disease. Look at this prevalence of MASH in high risk population. 66% of patients have diabetes and MASLD. 34% have MASLD and obesity, and 49% of patients with hypertension have MASLD. So no wonder that these conditions are potentially not only intersecting, but maybe consubstantial. Indeed, not only there are, commonalities of this condition together, but they do expose to high risk of cardiovascular diseases, each of them contributing and self-aggravating or aggravating the other conditions. People with MASLD and diabetes, for example, are at an increased risk of cardiovascular events. They may develop cirrhosis, but before they get to cirrhosis, actually, they will die from cardiovascular cause, either from myocardial infarction, stroke, or heart failure. And there is a commonality also of outcome when it comes to cardiac, but also to renal. And this is also a common pathophysiologic background. Liver fibrosis score is a very strong predictor of cardiovascular events in patients with heart failure. Heart failure, the preserved ejection fraction. This is taken from the TopCat study, a trial with spironolactone in patients with HFpEF. And you can see that indeed that the frequency of liver fibrosis was very high, and the severity of fibrosis strongly predicted cardiovascular events, and therefore liver fibrosis is a cardiovascular risk factor. Now, NAFLD predicts also the incident CKD, not only of heart failure events, but also chronic kidney disease and aggravation of kidney disease in patients with diabetes and without diabetes, by the way, even in patients with heart failure. So again, fibrosis and NAFLD are not only liver risk factor, but cardiovascular and renal risk factor. Disease severity in muscle drives also atherosclerotic cardiovascular disease and dyslipidemia, triglyceride, obesity, high cholesterol, and all common risk factor across cardiovascular, atherosclerosis, diabetes, and MASLD. And finally, the goal of management of MASH is not only slowing the progression from steatosis to liver fibrosis and cirrhosis, and preventing what we call MALO, which is the major adverse liver outcomes, but it's also, and maybe before this, preventing major adverse cardiovascular events, because indeed, patients before they may develop liver cirrhosis, liver malignancies, or adverse liver outcomes, they may, and most of them actually, they would have a cardiovascular event or develop CKD or die from cardiovascular disease. And we have unified this concept in one single word, which is the cardiovascular kidney liver metabolism syndrome, CKLM, because all these conditions stem from the same common risk factors: diabetes, obesity, dyslipidemia, hypertension. They all progress across the same pathophysiology and underlying mechanism, which is neurohormonal activation, insulin resistance, inflammation, fibrosis, endothelial dysfunction, and oxidative stress. And then, depending on the initial presentation, the same patient can get presented first as a MASLD patient or a heart failure patient or CKD patient. But this will self-aggravate until patient may develop 2 or 3 conditions at once. And therefore, no wonder that there are medications which are targeting all this condition together. SGLT2 inhibitor, GLP-1 receptor agonist, CHIP, anti-inflammatory medication, and FGF21, mineral receptor antagonist. All of these have as common to be effective in heart failure, in diabetes, in CKD, and in MASLD. They are being developed in MASLD. So these are really typically what we should aim at, breaking down the silos. Now, there are multiple targets which are being investigated for the treatment of MASLD and MASH, and this is a very busy slide just to show you that these multiple targets are targeting common mechanisms, and therefore they may be producing drugs which may be hitting multiple birds with a single stone, with a single medication. And therefore, metabolic health should encompass cardiovascular and renal as much as liver health. And in order to make progress within this complex area, because patients are, having multiple comorbidities, but more than comorbidities, consubstantial mechanisms, we may need to get to personalized medicine and disentangle this heterogeneous population by molecular phenotyping. And there is a very important development of biomarker on the hepatologists call this non-invasive test and mechanistic biomarkers, which may in the future help distinguish subgroups of patients who are more responsive or potentially more eligible to specific drugs. But for the time being, we are having drugs with combinatorial efficacy, single drug treating the heart, the kidney, and potentially the liver. And this is the case with GLP-1 receptor agonists and SGLT2 inhibitors, for example. I'm borrowing this figure from a patient advocate from the Fatty Liver Foundation, Henry Chang. He calls it the trinity of liver, heart, kidneys. And this is typically, again, breaking the silos and considering this condition as a single entity, because by the end of the day, the objective is to treat the patient, not just the disease. The patient has got consubstantial conditions, kidney, liver, and heart altogether, and we need to do a better job with combinatorial agents and develop clinical trials in this condition together and have the regulatory framework also evolve as to approve drugs concomitantly for these single comorbidities together as to achieve combinatorial agent, approved combinatorial agent. And this is indeed actually in the benefit of multiple stakeholders, this new concept of consubstantial condition rather than siloed disease. The patient, because is unique, and the patient may present to a cardiologist, hepatologist, or nephrologist, by the end of the day, each of these specialties should screen for the other comorbid condition. Industry need to consider the drug development within this new framework as to target multiple population in a single trial and have multiple endpoints in the single trial. And finally, the provider should consider treatment of one disease impacts the course of others and hopefully decreasing the safety signals from all these diseases. So the future is bright, and the future should be really influenced by this new way of thinking, breaking down the silos and considering that condition as a single condition with multiple types of clinical presentation, multiple outcomes, and we need to have a unified clinical trial enterprise and evidence generation enterprise, and think about combinatorial agents with a single agent treating multiple diseases. And you have on the left-hand side the siloed views we need to get away from, and the right-hand side of this slide, the integrated views with common underlying mechanisms and therefore targeted with the same medication. Thank you so much for your attention.
Professors, esteemed guests, I'm Nicholas Chew. I'm a clinician scientist and an interventional cardiologist from the National University Heart Centre, Singapore. My interest is in cardiovascular liver metabolic health, and I'm privileged to give this talk on the screening and diagnosis of MesoD in cardiovascular disease. I have nothing to disclose. Our group recently brought together an international panel of 20 cardiologists and hepatologists, endocrinologists, bariatric surgeons, nursing, allied healthcare in providing recommendations on the screening, diagnosis, and management of MesoD in cardiovascular disease. This document offers guidance for clinicians in the cardiovascular field in the screening and diagnosis of MesoD through the lens of a non-hepatologist. To achieve this goal, we use a two-step Delphi approach to facilitate the incorporation of the literature on the screening and diagnosis of MesoD into a consensus-led clinical pathway. For the diagnosis of MesoD, the MesoD diagnostic criterion should be used instead of the formal NEPHOD criteria, which includes evidence of hepatic steatosis identified by non-invasive tests or biopsy and presence of more than one of the 5 cardiometabolic criteria. A clinical consequence of identifying individuals at higher risk of hepatic fibrosis is the initiation of more aggressive cardiovascular risk reduction strategies in this high-risk group. As such, the screening for MesoD in patients with obesity, metabolic syndrome, type 2 diabetes, or those with high risk for cardiovascular disease is recommended. Clinicians must also remain aware that the burden of MesoD in lean individuals is not negligible. In those of normal weight with metabolic diseases, screening for MesoD should be considered. The consideration of MesoD should not be dependent on the presence of abnormal liver serum test, although persistently unexplained abnormal liver serum test should be evaluated. Although moderate to severe steatosis can be reliably determined with liver ultrasound, the sensitivity and specificity of ultrasound appear to be insufficient, especially in individuals with concomitant obesity. Liver ultrasound only provides a semi-quantitative liver fat assessment, and the absence of steatosis on ultrasound does not exclude the presence of MASH or fibrosis. Steatosis scoring systems such as the fatty liver index or the hepatic steatosis index have been proposed as alternatives in the identification of hepatic steatosis, but are limited by relatively low sensitivity. Individuals with MASLD should be evaluated for additional causes of hepatic steatosis, such as alcohol, and undergo investigations for secondary causes of liver diseases, such as hepatitis. The routine use of liver ultrasound is questionable, as the vast majority of people with obesity and type 2 diabetes already have steatosis, but rather the evidence points towards screening for clinically significant fibrosis in the higher risk population. The higher risk population includes those with type 2 diabetes, obesity with metabolic complications, or individuals with 2 or more cardiometabolic risk factors. And in clinical practice, we can use the fibrosis 4 index as a screening tool, given its strong negative predictive value. The fibrosis 4 is a simple equation that uses readily available labs such as platelet count, AST, and ALT. A FIB-4 of less than 1.3 is associated with strong negative predictive value for advanced fibrosis and may be a useful threshold to exclude advanced fibrosis in the cardiovascular disease population. FIB-4 of more than or equal to 1.3 indicates an intermediate probability of advanced fibrosis, and FIB-4 score of more than or equal to 2.67 has a high likelihood of advanced fibrosis. And both the intermediate and high-risk groups warrant secondary assessment and hepatology referral. Clinicians can consider the sequential use of serum-based and imaging-based modalities such as fibroscans to improve sensitivity and specificity in the diagnosis of fibrosis, especially in individuals at intermediate or high risk of hepatic fibrosis. The management of individuals with MASLD assessed to be at low risk of hepatic fibrosis based on the FIB-4 score can be managed by clinicians within cardiovascular specialty with the focus on lifestyle management, cardiovascular risk reduction, and the regular reassessment of fibrosis. Those identified at higher risk of fibrosis may prompt clinicians for the initiation of more aggressive cardiovascular risk reduction strategies. Because cardiovascular complications often determine the clinical outcome of MASLD, the document recommends the screening for MASLD using standard ASCVD prediction tools in all individuals with MASLD, regardless of the presence of atherosclerotic risk factors. This should include detailed risk factor evaluation at a minimum. Patients with MASLD should be screened annually for type 2 diabetes, hypertension, hyperlipidemia, and obesity. MASLD has been an underappreciated risk enhancer in the primary prevention guidelines, although it is likely to move into the same category as chronic kidney disease. The recognition of MASLD as a cardiovascular risk enhancing factor will be the next crucial step in promoting cardiovascular liver metabolic health. And with the emergence of cardiovascular kidney metabolic health, MASLD will likely head in the same direction as chronic kidney disease. The diagnosis of MASLD should be considered among cardiovascular risk-enhancing factors, with a greater focus of integrating MASLD into cardiovascular kidney liver metabolic health framework in upcoming preventative cardiology policies, strategies, and guidelines. Future large-scale studies are needed to examine the clinical utility and cost-effectiveness of using the presence of MASLD as a risk-enhancing factor to guide decisions on statin initiation, particularly in individuals at borderline or intermediate ASCVD risk. Moving forward, there is a need for shifts in treatment strategies that involve changes to clinical workflows, multidisciplinary care, integrated obesity management, and equitable access to metabolic pharmacotherapies. Stronger collaborations between cardiologists, hepatologists, nephrologists, endocrinologists, and the wider multidisciplinary team will be important in upcoming cardiovascular trials. Thank you for your time, and we hope that this offers the opportunity for wider collaborative efforts. Thank you.
Good afternoon, good morning. I'm Professor Cyrielle Cossy. I'm an endocrinologist and nutritionist at Lyon University Hospital, and I will talk about the management of metabolic dysfunction-associated steatotic liver disease in cardiovascular disease. We've talked about screening previously, and I will directly then move to what we can do once we have identified a patient with MASLD and potentially also with more severe stages, such as MASH or fibrosis and even advanced fibrosis. And as you can see here, the first step is really taking care of lifestyle modification. This is very important. For the sake of time, I will not go in detail, but these are the last recommendations from the EASL, ESD, ESO guidelines for the management of MASLD. And as you can see, the first step is really trying to induce weight loss. If you want to achieve improvement in steatosis, having a weight loss greater than 5% may be enough. But if you expect improvement in MASH and fibrosis, then you should target for weight loss above 7 to 10%. Diet is very important as well, and especially the quality of the food. So what we know is that minimizing processed food and ultra-processed food is key, and also sugar, sweet, and beverages. And the preferred diet for the resolution of MASLD, MASH, and fibrosis is Mediterranean diet, which is also being proven to be beneficial for cardiovascular risk of outcome. And of course, physical activity also will be very important and engage patients to move more. What we know also is that it requires time, multidisciplinary care, lifestyle evaluation during healthcare visit, which is not really easy to do. And we really need to have the support of a coach and a dietitian for that, which are not always affordable and reimbursed. And we really need support from a healthcare system for that. And sharing resources could be a good idea because these patients navigate between several multidisciplinary care already. So this is key, but this is not the only thing you can do for your patient. And again, I will just follow the most recent guideline from EASL, ESD, ESO. It's also available to download in the EASL app if you want to look at them in detail. And as you can see, there's many things we can do for a patient. There are MASH targeted therapy that are coming in Europe and already available. I will talk about that just after this. But you can also try to optimize therapy of diabetes, obesity, and dyslipidemia. So first, what you can do if you want to directly target the liver and have a specific MASH targeted therapy, even though it's not yet approved in Europe, the guideline has already anticipated that we are hopeful to get this treatment. It is FDA approved in the US for more than a year now. And as you can see, it's a thyroid hormone receptor beta selective, specific in the liver, that will basically restore the balance between thyroid hormones only within the liver by activating the iodinase enzyme that will improve globally the liver metabolism. This has been effective and showed in a randomized phase 3 trial. Here I'm showing you the main result of the interim analysis, where you can see that patients treated with resmetirom 80 or 100 milligrams have a significant higher proportion of patients with MASH resolution without worsening of fibrosis, but also a significant improvement of patients with the fibrosis improvement without worsening of the NAFLD activity score. And with a good safety profile, the main adverse events were diarrhea and nausea that were mostly mild to moderate. So the study is ongoing. This is also very important, and we are now assessing if the treatment is able to improve and reduce liver-related outcome in the long term. Moving on to dyslipidemia, we know that our patients with mast cell disease sometimes have a mild or elevated liver enzyme, and for some physicians may be reluctant or worried to introduce a statin in this context. What we really needs to be known is that statins are safe in patients with MASH, and these patients are mostly dying and having cardiovascular disease. So this is really super important, easy to do. Statins are widely available. Here I'm showing you one example from Hong Kong, which is a territory-wide study with more than 16,000 patients with type 2 diabetes and mast cell. And as you can see, even though it improved over time, and then they look on the period between 2000 and 2020, the patient will achieve individual LDL cholesterol target has significantly improved, but they're only at 74.3%. We can do better. And if you take a global look at the overall cardiovascular risk factor management, only 18% achieve their individual goals for HbA1c, blood pressure, LDL-C dose. So these are very simple things that needs to be reminded. Make sure that your patient with mast cell are on target for all these cardiovascular risk factors, and this would be very beneficial for them. Then we can also look at what is possible in terms of management and optimization of comorbidities. And I will start with obesity. There are many options now that we can for patients with obesity. GLP-1 receptor agonists and co-agonists are now available. And of course, bariatric surgery intervention are good. And when we look at what the benefit could be in terms of managing mast cell, we have a lot of new evidence showing benefits. Here I'm showing you the most recent results that has been presented at the liver meeting. It's not yet published, but we are expecting a publication soon from the phase 3 randomized control trial, ESSENCE trial, that has assessed the efficacy of semaglutide 2.4 milligram weekly compared to placebo in patients with MASH and fibrosis F2 and F3. These are the results of the interim analysis after 72 weeks of treatment. And as you can see, there's a significant higher proportion of patients who achieve MASH resolution in the treatment arm with semaglutide compared to only 34.1% in placebo arm. And we also have observed a significant improvement in fibrosis, liver fibrosis lesion in a patient with semaglutide with 37% improvement compared to only 22% versus placebo, and this was significant. The study is ongoing. This is also very important, and it will last more than 4.5 years. And again, we will look at the end of treatment of the benefit in terms of liver-related outcome, but also as secondary outcome, the cardiovascular outcome will be looked at. This program is less advanced. This is the randomized controlled trial in phase 2 for the tirzepatide, which is a dual GLP-1 receptor agonist that has assessed also the efficacy at the 3 doses that we use in obesity and type 2 diabetes, 5, 10, and 15 milligram compared to placebo. As you can see, the patient with NASH and F2 and F3 enrolled in this study have demonstrated a significant dose response in terms of improvement of MASH resolution with no worsening of fibrosis, up to 62% compared to only 10% in placebo arm. And there were no dose response, but a higher proportion of patients that achieved fibrosis resolution compared to placebo. This was not a pre-specified primary outcome, but still the results are very encouraging. So when we look also at the more severe stages, I just wanted to highlight as well this important study. This is a phase 2 randomized control trial that has looked at the efficacy of semaglutide 2.4 milligram in patients with compensated cirrhosis, F4. I did not demonstrate a higher efficacy in terms of liver fibrosis improvement and MASH resolution compared to placebo within a period of 48 weeks. But we do have no data that shows a satisfactory safety profile. We do see the common GIFI side effect that we observe with GLP-1 receptor agonists, but no alteration in liver function and kidney function And it's really reassuring also for the patient that would like to initiate that. This is a study that lasted only 48 weeks, and maybe it's not long enough in this patient with very severe stages and cirrhosis to observe improvement. And this is what we learned from the bariatric surgery studies. There are many studies that has demonstrated the efficacy of bariatric surgery in terms of resolution of MASH and also liver fibrosis. I chose this one because this one published in Gastroenterology in 2020 as the longer period of follow-up up to 5 years. What we need to see here is that the improvement in MASH that you observe at 1 year is sustained after 5 years with 84% of the patients that improve MASH and have a MASH resolution. And it depends, of course, on the magnitude of body weight that you have achieved and lost within bariatric surgery. For fibrosis, if you look at the distribution of fibrosis, clearly 1 year is not enough, and the benefit is observed after 5 years, where there's a significant higher improvement of liver fibrosis. Looking at the baseline severity, it is easier to achieve fibrosis resolution in patients with F1 and F2 up to 62%, and in patients with F3 and F4, it's less than 45% as a benefit, but still this is a very good result for patients with very severe fibrosis such as F3 and F4. So if we want to summarize this in this table, what you can see is that we have benefit in terms of steatosis, MASH, and fibrosis with both strategy, treatment, pharmacological treatment, and bariatric surgery. And in terms of choice for compensated cirrhosis, in semaglutide, it is safe, but will not probably improve in the period of time of approximately a year, whereas we have evidence for bariatric surgery. For malo, which are the major adverse liver outcomes, we don't know yet, but the ESSENCE trial is going to provide data. We need to wait a little bit longer. No evidence yet for tirzepatide, and there are evidence and studies that shows an improvement after bariatric surgery. For cardiovascular outcome also, we do have evidence with semaglutide, but in obesity and type 2, we need to have data specifically in patients with MASLD. The cardiovascular outcome with tirzepatide is ongoing. We are expecting the results soon. And we do have also benefit for cardiovascular outcome with bariatric surgery. So here is basically what you can expect and explain to your patient when you engage them and try to improve the liver status based on this intervention. Finally, I will go a little bit more quickly on type 2 diabetes. You see that we do see the same therapy, GLP-1 co-agonist, and also SGLT2 inhibitors and metformin are the option that you could favor in patients with type 2 diabetes and MASLD, and this is a way to optimize also their treatment. If you look at the summary of the data, of course, you see the same result with GLP-1 receptor agonist, but keeping in mind that the data that we have are mostly for the dose of anti-obesity. There is not a lot of data with GLP-1 receptor 1 milligram weekly, but we expect that is probably mediated by weight loss and potentially then achieving the same result. Tirzepatide has demonstrated an efficacy on every lesion, hepatic steatosis, MASH, and fibrosis. And we also have evidence of improvement of hepatic steatosis with the SGLT2 inhibitors. Resolution of MASH and fibrosis are less strong. There are some conflicting results with very small studies, potentially a benefit. Pioglitazone as well is an option to improve hepatic steatosis and MASH, but limited in their use because of potential side effects, including body weight increase. Most interestingly, when we look at liver-related outcomes, there's been many studies published over the past years that has provided data from retrospective observational studies from very large healthcare databases that indicate that potentially GLP-1 receptor agonist, the dual GLP-1 agonist and SGLT2 may have benefit in terms of reduction of HCC, reduction of hepatic decompensation and cirrhosis. So potentially we do have also a benefit for the patient. This will need to be demonstrated in proper randomized control trial, but still this supports the optimization of the treatment. And finally, metformin has been tested there is no improvement in the MASLD lesion, but again, some studies seems to indicate that there may be a benefit in terms of reducing liver-related outcomes, and so you can keep the patient on metformin until it's contraindicated due to hepatic decompensation. So to summarize these are the European guidelines, but yeah, it has also been recently reinforced by the American Diabetes Association Standard of Care guidelines, released this year. As you can see, they are totally aligned, and they can tell you that they can indicate which anti-diabetes therapy you can prefer, GLP-1, GLP-1 receptor, pioglitazone, or GLT2, with the caution of patient with compensated and decompensated cirrhosis, as I told you, not a lot of safety data, so needs to be prescribed with caution in this patient, and anti-obesity therapy, of course, are also there. So as a summary and take-home messages, these are what we wanted to cover today. Don't forget that lifestyle modification are key, and any intervention that you will provide to your patient will be more efficacious if you enroll them at the same time with lifestyle modification, but it may not be enough. And there's many things we can do. MASH targeted therapy, hopefully coming soon in Europe, already approved in the US, and all the panel that you can optimize depending on the patient profile in type 2 diabetes and patient living with obesity. Are option that you can choose in having in mind that it will have a benefit in the liver, and don't forget to treat dyslipidemia with statin. One thing also that I did not mention previously is that you may need to make sure that patients that are identified with compensated cirrhosis F3 engage with the hepatologist and have a screening for HCC, hepatocellular carcinoma, because this will really also change the prognosis of the patient. And with that, I would like to thank you for your attention.
Great. So thank you very much to our speakers for some fantastic presentations there. So we're now entering the question and answer session now. And I can see there are some questions on the in the box already, but I would encourage those in the audience, if you've got some questions, to add them now. I noticed that there's one question that really stands out, and that's about the role of using GLP-1 receptor agonists in actually non-obese patients. Maybe could the panel perhaps give some reflections on that, whether there's a role for not just using it in obesity, but in non-obese patients and lean MASH?
Maybe I can start. Happy to take this question. The only issue is that the evidence, so you can use, and really keeping in mind that you will need to prescribe the drugs in their indication and approve indication depending on the countries. We do see that there's benefits in obesity. You can optimize if there is an indication for type 2. What is less known is whether and I think this is the question, whether you should use GLP-1 receptor agonist in the indication of MASH without the indication of type 2 diabetes and obesity. I think we really need to wait to have more data. We need to see the publication of the ESSENCE trial. These are purely MASLD. Not all of them have obesity, but they were selected for cardiovascular risk factors and metabolic risk factors. So be caution, because also what has been shown in the guidelines is that for lean patients, you may need to achieve less magnitude of weight loss, and you don't want to induce, denutrition. And so I think at the moment, we need to be cautious and probably keep the GLP-1 receptor agonist in their indication and approve the indication.
You're on mute, Michael.
Right.
Oh,
patients. So often the problem is that we might introduce them at a different phase. We might be concerned about the heart indications and not consider the other ones. And there are differences in terms of regulatory approvals, indications, reimbursement profiles. So for the next couple of years, it's going to be quite tricky. And what we really need is to have close dialogue with other disciplines. We've already worked very closely with the kidney doctors, now increasing with diabetes doctors, the obesity doctors, and the liver doctors. Clearly for MASLD will be incredibly important. So we just need to get better, and we need to get rid of those boundary effects that also affect our regulatory authorities.
No, thank you. And can the panel see that will have more of a one streamlined approach with these patients, or do we still need to have quite nuanced specialist care? What do we think about that?
Yeah, we definitely need to have a more nuanced understanding of MASLD as a whole, because it's a very heterogeneous condition. We need more data on understanding the heterogeneity in the contributors of MASLD pathophysiology that can result in differential rates of MASLD progression, the relationship with cardiometabolic diseases, or even metabolism-based treatment responses in the whole spectrum of MASLD. So it's definitely not a one-size-fits-all approach. Even more so with cardiovascular disease, understanding the cardiovascular risk of a patient, whether the atherosclerotic cardiovascular risk profile is higher than the heart failure profile or vice versa. That would definitely guide the management in terms of whether we stick with the SGLT2 if the patient is a higher propensity towards heart failure, or if it's atherosclerotic cardiovascular disease, there is high evidence with the GLP-1 receptor agonists.
Sorry, I would like to ask you a question concerning these points you just made. We need the evidence, and we have so large trials, outcome trials in cardiovascular medicine. And I've seen when you look at bariatric surgery, you have it biopsy control. So that is impossible in these large trials. And you correctly stated that FIB-4 scores and other scores are screening tools. Would you accept, when we go into cardiovascular trials and look at the scores, to see the movement of these scores and then related to cardiovascular outcomes? With that an approach? Or are these scores too much confounded by congestion, for instance, in heart failure, that it would be not reliable, right? The trials you showed are small. We have the big trials, but we do not have these in-depth analyses of liver pathology.
Yeah, I totally agree with you. And sometimes it's disappointing to see that there's been so large clinical trial that was performed for cardiovascular outcome, but very poor data regarding the liver phenotype. So definitely we can look at signals. FIB-4 may be one. It's not the best, but it can be an option when you have such a large panel in order to stratify your patient based on the risk of having fibrosis or potentially advanced fibrosis. The biomarker that mostly used in the hepatology field would be transient elastography, but as you said, there may be confounding factors due to congestion. So that's also something that we need to take into account. I think really there's also other biomarker like the ELF health test, and these are blood-based biomarker. Overall, we need to maybe combine them. And if we have a strong signal moving towards an improvement, that would be something that we can consider. And I think this is really important to look at. And I really think we should try to make sure when we are designing new large trial to have a minimal liver phenotype as well, because this is really important. And if I may just in a couple of take the time to come back to the multidisciplinary approach and the holistic therapies that can now target multiple organs. I think this is really something that will bring us to a new area. One drug will not fit all, but we will have many options. And this is really something that we need to learn how to navigate with that, to find a good treatment for the good the good patient profile. And with that, I think we're really entering in a personalized medicine practice now, when we will be able to navigate between different type of profile. There's been a very nice study that have shown when you do the clustering of the patient with MASLD, some will develop cardiovascular outcome, some will not. So we will be able potentially in the future to better understand the trajectory of our patient and choose the right treatment. Is it a liver targeted treatment or is it a more metabolic targeted treatment? This will be very important to take into account.
Is it another confounding or even an effect?
Okay.
I'll add to that. So the in terms of MASLD, there is evidence that is showing that there is some form of association with patients who are well controlled with statins. They do have actually they can have reductions in serum transaminases. In fact, these hydrophilic and lipophilic statins have been shown to actually improve liver outcomes. But of course, there's always a caveat that in terms of individuals with severely deranged serum transaminases, the statin definitely has to be withheld. The prevalence rate of drug-induced liver injury is actually quite low if we look at the evidence there. So definitely statin should be continued, and it doesn't necessarily increase the risk of cirrhosis. Yeah, that's just to answer the question of the statin-related transaminases.
Yeah, there's been a lot of studies that show that there is that you can achieve improvement in all sorts of diet, ketogenic diet as well. Time-restricted feeding as well is something that is very fancy at the moment. They all have demonstrated some efficacy. Most of the time, the efficacy goes through the weight loss. So any diet intervention that will induce weight loss and decrease your calorie intake will be beneficial in terms of improving MASLD. My only concern is that with all this type of diet, for example, the ketogenic diet is not sustainable. You cannot keep on this diet, and there may be health issue if you just keep that on the long term. So what we see also is that when people stop, they will gain again, and this is the typical yo-yo effect that we see in many of our patients. So that's why the Mediterranean diet is more like a modification of lifestyle that is sustainable and that you can really engage and try to change your habit and dietitian habit for long term. And this is also why, in my personal opinion, I think this is much better in terms of sustainability and try to really engage the patient to change, but for a lifelong period of time. So this is my only concern regarding all this type of diet that are not really sustainable in the long term.
Thank you. And what about, so one of the other things with the GLP-1 agonists that you see is a lot of patients are at risk of developing sarcopenia and muscle loss. Do the panel have any thoughts around that? Because obviously that's also very important when you're looking more holistically at the patient in terms of all of the outcomes. Any thoughts there?
I'm happy to go. I mean, certainly it is an increasing issue with weight loss. You get 30-40% of the weight loss with this when treating patients with obesity will reduce skeletal muscle. And so you really do need some strength training to make sure that the muscle has a stimulus for growth and possibly an enhanced protein diet. My concern is if widespread use of these effective anti-obesity agents for lifestyle purposes, then patients might take a treatment, then stop, and the weight regain can be more fat enriched. So this idea of cycling GLP-1 receptor agonist or dual action agents may be causing some harm. We don't want to replace obesity with sarcopenic obesity. That would not be helpful.
Yeah, I totally agree with this. And if I may just, we need to be reminding that these are chronic diseases. And once you engage in treatments such as anti-obesity treatment, we need to be aware that it's, again, going to be a chronic treatment. if we want to avoid this issue. This is very important.
The question is also whether this is a general issue, whether you lose bariatric surgery, GLP-1, and maybe just diet, because in all of these methods, you lose also muscle, fat-free mass. And the question is whether there is a difference. In the literature, as far as I understood, there is not much of a difference between the different modes of weight loss. Andrew, is it true? Or do you think there is a differential specific effect of GLP-1?
No, I don't think there's specific to the cause of the weight loss, but obviously the severity of the weight loss is much greater with the more active agents, and the risk that patients will simply start and stop, particularly if it's still quite expensive, where there's a financial incentive not to keep going. I don't think when they're being used for a serious illness that says higher risk, because there'll be a physician. But when patients are getting their drug prescriptions through internet prescriptions or purely for body weight, then I think it's a much greater risk of intermittent therapy.
Good.